Okay, today we are gonna see how to report an MRI brain. I'm starting with a very simple case, and normally what I do is I start with the sequences which are in the order given to me, but different people have different approaches. Some want to start with diffusion, some start with T2 flare, but since I rotate through multiple hospitals, and each hospital has its own set of sequences and each order of sequences, so that I don't miss any sequence, I go from top to bottom or left to right. And we are going to do that today and see all the sequences, including the localizers. Make sure you see the localizers also every time you read an MRI, because sometimes they have things which are not easily noticed on the main images. Starting, let's see this. This is a T2 flare image. We can see that the CSF signal is suppressed, all the fluids are suppressed, and we don't see much here, a good gray-white matter differentiation. There's no white matter hyperintensity seen here to suggest any pathologies. We can also see a good clear picture of the mastoids, and the middle ears look clear. The paranasal sinuses look good, the orbits look good. We can see that there is small amount of space here in the retrocerebellar region, more on the left side. Uh, we'll come to that later. And next we go on to the diffusion images. Now I always like to compare with the ADC map when we do the diffusion images, and because otherwise we're gonna miss stuff, and that's how it's done. So we're gonna put side by side the diffusion and the ADC maps, and we can see that there are no areas of restricted diffusion on the and no corresponding low signal on the ADC maps. So it looks good. That region which I talked about, there's no restricted diffusion. Now coming to T2 weighted images. T2 weighted images also look good in this chart, in this person. He's a 30-year-old with coming with loss of sleep, no other symptoms. There is a small CSF space here which is prominent, which is abutting or mildly compressing the left cerebellum. I'll say abutting. And it has no communication with the fourth ventricle. The vermis looks great. The rest of the cerebellum looks great. The brainstem looks great. So the overlying occipital bone, I don't see any remodeling. There are no vertical septations or any septations in this. And it demonstrates fluid signal, which is similar to the CSF. Next are the sagittal images. In sagittal images, I always make sure I see the sella and the suprasellar region. We can see the pituitary gland. We can see the pituitary stalk well. The clivus is another region which I want to have a look. The dens, sometimes there are degenerative changes or small abscesses or epidural abscesses which need to be seen. Make sure you see the brainstem and the cervicomedullary junction, and uh, that has some abnormalities sometimes. In this person it's normal. Look for tonsillar herniation. It doesn't have any. It's well above the foramen magnum. Make sure to look for fusion of, sometimes there's fusion of the C2, and sometimes there is atlantoaxial abnormality. Make sure you look for the distance between the dens and the anterior arch of the C2 vertebra. Always make sure that you look at the tongue, the nose, and the mouth, because sometimes the thyroid is seen, because sometimes there's an obvious finding but we just miss it because we are not looking there. Have a good look at the corpus callosum. Make sure it's well formed. There are no abnormalities. And so those are the things which you need to see. On the coronal, I would like to see not only all the structures but also the orientation of the hippocampus. Make sure the temporal horns are normal and not dilated. That will mean some volume loss. And I would also like to see the temporomandibular joints, the C1, C2 joints, because sometimes there's dislocation or degenerative changes, and that might be causing his his pain rather than any actual brain pathology. And the next we see are the GRE images. In these images, we look for bleed or calcification. Not all calcifications are seen on GRE, but bleed will show up. We can see that in this person, there is no area of blooming or low signal on GRE images. And these two tiny dots are most likely calcifications in the basal ganglia region. And then we can take the T1 flare images and we can see that everything looks good. There's no T1 hyperintense lesion, neither is there a hypointense lesion. We can see that the retrocerebellar cystic structure or space is following CSF signal on all sequences. And these are the diffusion images. The ADC maps. These are the localizer images. Everything looks good. So except for that small retrocerebellar space, which is most likely an arachnoid cyst rather than megacisterna magna, we don't see anything. And so that's what we will report, that this is a person with a retrocerebellar cystic space measuring this by this by this centimeters, and likely an arachnoid cyst.